FISH testing, short for fluorescence in situ hybridization, is a powerful tool used in multiple myeloma to uncover hidden genetic changes in the cancerous plasma cells. FISH reports can be confusing because labs don't yet follow a standardized format. In this HealthTree University lesson, you will learn what FISH testing is, when this testing is done, what probes should be used, and how results are reported. What is fluorescence in situ hybridization or FISH testing?
FISH, which is an acronym for fluorescent in situ hybridization, measures for genetic abnormalities in the cancer cell. One of the characteristics of all cancers is there's mutations in the cancer cells. Their DNA goes haywire. And that's true for every form of cancer, and in myeloma in particular, you can find changes in the myeloma cancer cell that isn't present in normal plasma cells in the bone marrow. And it's one of the defining hallmarks of cancer is these genetic abnormalities.
Once these genetic abnormalities are identified by FISH testing, patients are stratified into standard or high-risk groups. Knowing the genetic risk helps guide treatment decisions and tailor therapy based on how aggressive the disease is likely to be.
I think it's also important that when I talk about genetic mutations, we need to distinguish that from hereditary mutations. These genetic mutations are specific to the myeloma cell line. They are not part of any of the other cells. These are not inherited traits. These are not things that you're passing on to your children. These are only in the myeloma cells. So please distinguish genetic from hereditary.
To learn more about somatic and germline mutations, watch the video in Basic Genetics and Tumor Biology course. How is FISH testing done?
Different laboratories use different techniques, but typically there is what we refer to as a probe that identifies the genetic mutation.
Probes are tiny pieces of DNA. Each probe is like a magnet. It's designed to find and attach to one specific gene or part of a chromosome. These probes are tagged with fluorescent dyes. So when the sample is placed under a special microscope, the areas where the probes attach light up in bright colors. By looking at the color patterns and locations of these glowing spots, scientists can see whether pieces of DNA are missing, duplicated, or rearranged.
Now, these genetic mutations are not present in every single cell. Myeloma is a heterogeneous disease, and it's a mixture of different cells, so-called subclones, multiple different populations, some of which may carry the mutation, some of which aren't. So if you detect a specific genetic abnormality in the myeloma plasma cell, at what level do you consider it positive? And it is quite laboratory specific at what threshold they use, 10%, 15%, 20%. And so there's not one right answer for every laboratory because they have different thresholds in order to indicate that you are positive for a specific mutation.
So FISH testing is probably the most common genetic test done in multiple myeloma. And really what that means is we're able to look at chromosomes that aren't in cells that are divided.
As we covered in a previous HealthTree University lesson, cytogenetic testing with karyotyping requires actively dividing myeloma cells. But this can be challenging since myeloma cells typically don't survive or divide well in standard lab conditions. FISH testing overcomes this challenge.
We use a probe that fluoresces, and so we can see it with a color. And we can stain a cell, and we can look to see if that probe is where it's supposed to be or if it's somewhere else. And to do that, we use two probes of two different colors. And we can look to see if they're together or if they're separated. And that's how we look for some of the common genetic events in multiple myeloma, like the 414 chromosome translocations or the 1114 chromosome translocation.
What probes will be used on a myeloma FISH panel?
So there have been identified in the myeloma cells specific abnormalities that affect outcomes, that are predictive of poor outcomes shorter benefit from treatment. These probes involve chromosome 14, which detects changes around chromosome 14. It also looks at a specific loss of chromosome 17. That's very, very important. But there are also probes that just look for an increase in the number of chromosomes, which actually can be favorable, or multiple losses of odd-numbered chromosomes, 9, 11, 13, 15, that actually carry an adverse prognosis. So there's a panel of probes, each probe specific for a single genetic mutation. And we have different probe panels for leukemia, lymphoma, and myeloma. So there's a myeloma FISH panel that uses these specific probes. But the key abnormalities are chromosome 14, chromosome 17, and chromosome 1. There's actually an abnormality where chromosome 1 adds genetic material instead of loses genetic material.
Now, as a myeloma physician, there are a certain panel of mutations and translocations I'm interested in, and which I depend to see whether the FISH testing is positive for. Translocations of chromosome 14 are really important, which is translocation between chromosome 4 and 14, 11, 14, 14, 16, 14, 20, as somewhat characteristic of myeloma, and any changes in chromosome 1, be it a gain of chromosome 1, meaning at least 3 or 4 more copies of chromosome 1. Typically, there are only 2 copies, so anything 3 or 4 is abnormal. And if there is a deletion of chromosome 1, again considered abnormal. These are typically considered as one of the most common myeloma patterns. We also see deletion of chromosome 13 and the addition of odd chromosomes, the gain of chromosome 3, 5, 7, 11, 15, 17, 19. If you see that, again, highly suggestive of myeloma.
Does every lab use every myeloma probe?
With FISH testing, although there are lots of probes that can be used, not every lab uses every probe. Often there isn't enough material to do that. And so there has to be some selection as to what you look for. And it may differ from in a newly diagnosed patient and then in a relapse patient. And so often you might look for 5 different things when you do a FISH test.
So there have been many studies which have established that the mutations I alluded to before and the translocations I alluded to before, they tend to be what is called as a myeloma panel. There have been, again, in the past, when I've received reports from outside, they run a limited panel. They only run like deletion 17p, chromosome 1, and maybe one of the translocations of the chromosome 14s. But nowadays, there has been an integrated push to have the full panel tested so that we know exactly what is the genetic and the biologic subtype of myelomas.
Besides high-risk abnormalities, are there other mutations that may be probed?
So there are other translocations. 1114 is another one that can be seen. This one is important to know because it does predict for response to certain drugs. And I have had to go to these drugs at sometimes also response for chemotherapy and certain antigens like CD20 or on myeloma cells that happen to have this translocation. Again, I think myeloma is not one disease, it's multiple diseases, and some of these translocations do predict biology.
What type of test sample is needed for FISH testing? Where does it come from? And how should it be prepared?
One thing that's important when FISH testing is done, it's typically done on the bone marrow biopsy, but you want the pathologist to isolate the myeloma cells and do the test on those plasma cells. And the reason we want that is so that we're not getting normal cells diluting out what are the true chromosome abnormalities or genetic changes that are there in the myeloma cells. This is especially important when the percentage or the fraction of abnormal plasma cells is small compared to normal blood cells. So if a bone marrow has 10% plasma cell involvement, then the majority of other cells are our normal blood cell, like stem cells and other cells in the bone marrow. In that case, we especially want the isolation of the plasma cells.
Why is it important to make sure FISH testing is done on an enriched sample?
It is very important to do FISH properly that you have the right sample. Quite frequently, we see that people send just general bone marrow samples for FISH testing, and there's no method for enrichment of those cells, and there's no method for selection of those cells, so the results become unreliable. And what I mean by that is people are going to be doing the FISH testing and the scoring on the non-myeloma cells. They won't be scoring the myeloma cells. So then your sensitivity goes way down. And this is really not a good practice, because what happens is then, the patient might assume I don't have that genetic marker, when in fact, had you done it with either cell selection, or the other way of doing it is with a concurrent staining of the plasma cells with specific markers for them, then you would know that actually you're directly scoring the myeloma cells.
Would a patient know if their bone marrow sample was enriched for plasma cells?
So you have to read the FISH report. And what you have to say is whether it says SIG, CIG, SIG FISH, or whether it says that the cells were somehow selected or sorted. Often the patients might see magnetic beads or flow cytometry enrichment. But it's important to pay attention to that, as this might dictate, as I mentioned before, what kind of treatments we may do down the line.
Should the same FISH probes be used at relapse? Is this always done?
Sometimes not all the probes are used, just because institution or the pathologist might be using the same probes that were seen at baseline. But very rarely it can be that a chromosome abnormality was not detected at baseline but is identified on a relapsed sample. So whenever a bone marrow is done where there is disease burden, I think it's important to run these probes, since sometimes a FISH abnormality could have been missed in the first biopsy just because it may have a low clone size. But as the disease evolves, that genetic or chromosome abnormality is now the majority of the plasma cells and needs to be rechecked at relapse too. So I think whenever a patient has a bone marrow at relapse, they should be discussing it with their doctor and seeing if that is something that could be tested. There are rare situations where there may not be enough cells isolated, and in that situation, they may have to prioritize certain probes. But if there are enough cells, I think it's important that all the standard probes are run at the relapsed sample.
Who performs FISH testing?
FISH testing is usually done on bone marrow samples. The bone marrow is usually obtained either by me in clinic or one of our physician assistants or nurse practitioners in clinic, and these samples are actually sent to a laboratory where our colleagues, the pathologists, are the one who actually run these samples and do cytogenetics or FISH testing on it.
Can a machine or lab instrument perform FISH testing?
So generally, the FISH is done by a cytogeneticist. Although there are some machines that are capable of doing that, it's not widely done by a machine. It's usually done by a person.
What is found on a FISH report?
That actually depends on the reporting laboratory, so they're not all consistent with it. Typically, in most reports, there's the conclusion, and in the conclusion, it tells you what were the abnormalities found. But in the body of the report, they'll typically indicate which probes were used, although there are different probes produced by different companies. The probes even aren't the same. So knowing what chromosome probe is being used doesn't necessarily tell you whether they define what the threshold is to call an abnormality positive or not.
If you're confused by the FISH testing, don't worry, we are too. Because sometimes I get these FISH reports and I'm like, I need a PhD just on that to kind of understand what they did. Now, I think there is a movement to sort of standardize this process. There have been committees that have met. People have understood that this is a problem where lab to lab, sometimes it just depends on where you get the test done, where it's just, they put it in, they write the report in a way that's just, it's easy to make the wrong conclusions. But typically what I expect from a FISH test is which probes were looked at. We do want to look at all the high-risk probes. I want to see that's been done. Some FISH panels will actually concentrate the myeloma cells because sometimes there's a very small amount in the bone marrow and the test will be negative if you just do it on a bone marrow biopsy. So you actually want to concentrate plasma cells using flow cytometry and do it on a concentrated population of myeloma cells, you want to know what percentage of FISH probes actually bound and detected the abnormality. We'd like some standardization, and I'm hoping that that will be the future for us, where these reports will be all the same and not worded differently, where it'll be much easier to interpret. So I think there is a movement to do that. There have been some papers published recently about consensus groups, and hopefully we'll see more of that, and that'll help define this a little bit better.
A recent consensus paper from the Cancer Genomics Consortium specifically states standardization in FISH testing and reporting practices is needed. Because labs currently report FISH results in many different ways, it makes reading, comparing, and acting on those reports harder for clinicians, patients, and researchers. Without standardization, two different labs might test somewhat different probes, use different cutoffs, or report in different formats, making it harder for patients and their advocates to understand or compare results. We hope you learned something new from this video lesson. If so, give us a like and subscribe to our channel. To better understand the laboratory technologies used to analyze genetic abnormalities in myeloma and assess your risk status, watch the videos in Cytogenetic Testing in Myeloma course.